The views expressed on the Jerry Cahill CF podcast are that of Jerry Cahill and guests, and not necessarily those of the Boomer Esiason Foundation. Nothing on the Jerry Cahill CF podcast should be considered medical advice. Such advice can only be given by a physician who is experienced with cystic fibrosis. The Boomer Esiason Foundation, Jerry Cahill and guests cannot be held responsible for any damage which may result from using the information on this podcast without the permission of your medical doctor. You're listening to the Jerry Cahill CF podcast presented by the Boomer Esiason Foundation and jerrycahill.com.
Welcome to Jerry Cahill's Living, Breathing, Succeeding podcast series, The Path Forward with CF. This show, being a lung transplant coordinator, was made possible through an unrestricted educational grant from Chiesi to the Boomer Esiason Foundation. Today we'll meet Nilani Ravichandran, former lung transplant coordinator at NY Presbyterian, Columbia University Medical Center, and now Assistant VP to Cardiothoracic and Vascular Services at Newark Beth Israel Medical Center in New Jersey. Nilani has been a transplant coordinator for over 14 years in both heart and lung transplant.
My name is Nilani Ravichandran. I am the Assistant Vice President for Cardiothoracic and Vascular Services at Newark Beth Israel, which is part of the RWJ Barnabas Health System. For the past 17 years, I have been at NYP and Columbia University as a transplant coordinator, working in heart transplant and lung transplant. Being a lung transplant coordinator puts an added burden to be sensitive to the organ's needs in making sure that we minimize infections, as a result, minimize rejection. In the pre-transplant process, what we do is we wait for a person to be referred to us for transplant evaluation. And it's usually pulmonologists with different disease processes that would recommend the patient because there is no medical or surgical intervention that can benefit that person. So once we evaluate the records and we determine that this is a good candidate for transplant, then we call the recipient and we have a phone interview to make sure that the records that we have actually fits the person. And we bring them in for an evaluation to meet our team. And our team is usually the pulmonologist and the surgeon. And we have a one-to-one. We tell them to bring their family members with them so that we can understand the family dynamics. The patients coming in pre-transplant, unfortunately, they don't know what to expect. They don't know the enormity of what post-transplant care is all about. The disease got them to a stage where they now need a transplant, and they have faced that reality, and they come to us. However, what they don't realize is their post-operative care after a transplant is dependent on taking medications for the rest of their life. You have to instill values of how do you protect this organ. Yes, before you were protecting yourself, but now you're going to start protecting your organ. And that means washing your hands. How compliant are you in washing your hands? It's a completely new paradigm of lifestyle that they're starting. And it starts with simple as opening a door. Do you touch a door to open at the knob, or do you reach where everyone else opens the door, or do you reach the door up above where nobody else has touched it? In my entire career, it's one thing that I have always wanted to make sure that our relationship with a pre-patient is a smooth transition and that they feel welcome, they feel part of it. Because a happy patient, a happy relationship is a happy patient, and a happy patient is a successful transplant. So when a lung transplant patient is finally listed and is active on the list, the UNOS allocation provides a scoring system for lung transplant patient. It goes from 0 to 100. It's never good to be a 0. That means you don't need a transplant. It's never good to be 100 because you're really too sick for transplant. But the soft spots are between 40 to 60, I would say, 60 being a high score. Once you are activated on that list, if you're the right blood type, then organs will start to come in. So once the organs start coming in, there are coordinators, pulmonologists, and surgeons that are on 24/7 on call to receive these organs. I've had the pleasure of calling many patients and saying, come on in, we have your offer, we have an offer for you, it looks great on paper, we're waiting for a visualization. And once the organ is accepted, and then we fly the organ in, and you say, give your loved ones a hug, and you go to the OR. And next day you have lungs and you feel like a different person. So in the post-transplant world, the role of the coordinator is a little more complicated. One biggest issue is rejection. Second biggest issue is infection. The next biggest issue is not cancer in your first month or first year, but the longer you are out, the more the burden of these medications are on your body. We have to be sensitive. We have to be aware that it can possibly cause cancer. And that is what we always look for. Other side effects can also be, depression, and it can also have influence on guilt. Two people may have gone to the transplant at the same time, but the one person survived and the other person actually died prior. So we are sensitive to those things, and we protect you as much as we can with other medications that can prevent those from becoming an issue. We have found a formula that works, and we try to maintain that formula. I have been cursed and yelled and screamed at to say, I feel great, why do you want me to come back? You have my labs last week, this week I feel wonderful, I don't need to come back, my sister can't make it in and drive me in. But the answer is no, you have to come back. There is no compromise in that. The goal for a transplant is to make sure that we give you the best quality of life that you can possibly have at the end stage of your disease. And so as a transplant coordinator, I would say that it is very important to work with providers and organizations to do outreach to say that transplant is not a death sentence. Transplant is actually beneficial in maintaining a good quality of life.